Well, welcome back, everyone. ResearchWorks podcast here at the pre-conference workshop in Maulbronn for EACD 2025. And we have I'm going to call you a friend of the show because we've had you on before, Professor Stacey Dusing. Thank you for joining us today.
Absolutely. I'm thrilled to be here. What a beautiful place.
Beautiful place. Great topic. I saw what you'll be presenting over the course of this conference, and I loved every little bit of it. So I'm hoping we can just take it all in and talk about it today. Always love the topics that you have. But before we get started, I always love hearing about someone's background in terms of what brought you to this place and what do you currently do as your work.
Yeah. Thank you. I'm a physical therapist by background.
Love it.
And have practiced for a long time, over 30 years. And right now I am a professor and the Sykes Family Chair of Pediatric Physical Therapy, Health and Development.
I'm glad that you said that.
Yeah, at the University of Southern California in Los Angeles.
Wow. Okay. Gosh. So you have the clinical background. You're really in the research space at the moment. And one of the things that I love hearing you talk about is what therapy should look like, what it could look like as well as a call to action. And I know that one of the things you'll be talking about is play, which always sounds like a simple thing, but it ain't so, is it?
It is not simple. Play is not a simple thing. It's not simple to define, and it's definitely not simple to engage in your therapy. We've done a lot of work over the last few years at both defining play and thinking about how you integrate it into therapy sessions. And interestingly, many therapists say they do play, that it's part of their session. But in fact, when you watch their sessions, or if you sit down and watch a videotape with them of their own session, they'll say, oh, I'm not playing, I'm doing therapy with toys nearby, or with that toy being used as bait. When play is really a self-generated, by the child generated act just for the joy of moving and exploring and learning about that object. It has nothing to do with the goals of the therapist. So if the therapist has dictated the goals of the session, then they've changed it. It's not play. You can set the environment up to make the child more playful and to have their play maybe move in a direction you're interested in, but it needs to be self-generated by the child to truly be play.
Okay. So, I mean, I love that you always know something's more complex when you're trying to define the word. And play, by definition, as you've just described there, is self-generated. So I guess the contrast then, you've kind of touched on it then, but it'd be great to go into more detail because I'm also just listening going, okay. Which is great because we need self-reflection points. That's really important for us as a profession to keep moving forward. So what are some of the things that we think are play that aren't play?
I think a great example of that is when people say, I'm going to have the child do X, and they're going to do it in a way that's playing with this toy. And so, for example, working on walking, cruising along a piece of furniture, and every time the child gets to the toy, they pick it up and move it. It's like torturing the kid and saying, here, you can keep coming after this. It's bait.
And the bait.
Yes, I'm constantly giving, and well, of course that's play. No, that's not play at all. The child didn't choose it. You're not even letting them get the sheer joy of engaging with that object. And it teaches them that they have no say in what the activity is. So that takes away a part of their development.
That's really interesting. So it's more therapist-directed, not even word play, engagement. Rather than a child-initiated play, which is fun and beautiful and explorative.
Exactly. And you can set the play up to be such a beautiful thing and still reach the goals of your therapy if you understand what your goals are and why they're there. And then you understand enough about play and cognitive development and language development and motor development and how they're intersecting.
I love that. I love that. So in that instance then, that cruising instance, and I'm coming to this because I feel like I've definitely been guilty of it. It's like, come on to this, and I think a lot of people do it. And probably the reason why we do it is we've modeled it in front of each other for so many years, right? Generationally, we're probably teaching each other this. What should or could that scenario look like?
What a great question. The way that I look at that question unfolding is maybe the child is playing with that object, even if in the standing position. So you've encouraged them to get to standing to interact with it. But when they get there, they get the toy. And they get to engage with it in a different way. And maybe you choose a toy that easily will fall off the support surface, that will roll off the couch as a ball. And now they have to get down, go get it, and get back up again to put it in a container. but the child's driving that.
Yes.
So they're making the choices about, am I going to go get this or not?
Yeah.
So they're engaging, thinking about how the world works and how their actions are leading to new changes in the world.
Okay.
And how that play can then keep scaffolding, right? But it's child directed.
Right.
So I set the environment up to get them to do what I'm kind of working towards, but their practice and their play.
And so the role of the therapist in that instance is to be a few steps ahead, is to be creative with how that almost, I think like a child in terms of how they'd want to play, like not the proper way, I suppose, of how an adult would play. Would that be something that we need to think about too?
Absolutely. It's not even just the proper way to play, but it's also knowing where is that child in their understanding of objects and interacting. So take, for example, a child who doesn't understand the concept of object permanence, that when something falls, it still exists. If it's out of sight, that child who drops something off the couch and doesn't understand that ball that rolled away still exists, won't go get it.
Right.
So if you're focusing on that's what I'm going to do to have this child keep getting up and down to play with this idea of practicing pull to stand and cruising, well, they're not going to play that way because they don't understand the concepts from a cognitive perspective. And so we need to understand all the components of their development so we can set the play up both from an environmental standpoint, but also to meet their balance of their thinking skills and their motor skills and maybe their language skills, depending on what you're doing.
Yeah, because it really needs to satisfy all those components, isn't it? Because you want to drive more play, not to make it so difficult that you haven't got the just right challenge. And then go, I don't want to do that. And so you sit in your passive.
Exactly. And then it's about teaching parents that, right? Because you don't want to have it just happen in therapy because then you're not getting a large enough dose to meet the needs of any of our kids, let alone kids who have special needs or who have cerebral palsy. You know, we need a higher dose for those kids. So if parents can't understand that same idea of the just right challenge and setting up the environment for play, what you end up seeing is that parents use that toy as bait at home also.
And
now you're taking away play from that child, not even at home do they get to play. They get to chase bait all the time.
It feels like it's like a childhood fundamental right is you must be able to play because if you don't have, well, it's true, isn't it? You probably do need to have that to understand interactions with other people and how you actually move through the world.
And play is actually defined by UNICEF as a universal right of children.
Wow. Wow. So if I take it to another place where I think about examples of what therapy can look like. And we've touched on this before, and we have spoken about what therapy can sometimes look like. And, you know, we've talked about wooden boxes, we've talked about props and tools that don't really represent real life, and it's very facilitated by a therapist. And I think last time we spoke about it, we can see that there's an appeal with that in the sense that it's very formulaic. You do one thing, then you do this, then you do that, which I think makes it a bit more straightforward for a therapist. But then if I contrast it with play, you're asking the therapist to do something very different. It's not formulaic anymore, isn't it? Can you help me to tease that out a little bit? Because I feel like that's an area that I'm pretty sure everyone will be thinking about.
You know what? Children's lives are not formulaic. Children who drive their own actions, which we know is what leads to motor learning, they don't do things in an orderly fashion. So when we impose that on them in therapy, we're not helping their motor learning move forward in a way that would be consistent with their normal development or their normal progressions. And so we need to make sure that as we're thinking about setting up the environment or working with them therapeutically, that we're also following along with how children learn. And regimented, someone else directing their action is passive. It's essentially the same idea as saying, let me passively move you through these actions. And we know that that doesn't teach kids how to move or how to think.
How to think, and that's the part of it, isn't it? So one of the things I saw that you're going to be presenting on is the fidelity, which I saw it and went, oh, I love that. But how do you do that for play? Can you break that one down for me? Because I want to use it and love it.
And we have several papers looking specifically at the fidelity measures around some of our play-based interventions because it is really hard. And the big piece is that you have to understand what the goal is of what you're trying to achieve and set up those key principles. So for example, if your key principle is that the child is actively choosing what they're doing, and that you're not imposing movement on them, then you can set those as 2 key principles that you're going to look at.
Right.
And so, for example, in our scenario, we videotape our interventionists providing intervention, and we code minute by minute throughout that intervention session, are they following these key principles? And so they essentially get docked in fidelity if they're passively moving a child into a position because they're not supposed to impose movement within that. And if they're clearly taking away the action the child wanted to do. So I took away the toy they were playing with and gave them a different one because I want them to play with this. They're not facilitating the child's play, and that would count against them in fidelity. On the opposite side, we give them those points for saying, look, you spent all this time setting the environment up for this child to be able to play.
Yeah.
And by looking at our interventions in that detail, it also allows us to compare 2 different interventions. And so you asked the question about the box and the structure and the setup. If you look at a session that's been set up that way and look at the fidelity of it, you can easily quantify how much of the session was that child driving the action. How many minutes of your 45-minute session was the child choosing the activity versus in a session that's play-based and saying the play is the central part of the intervention. You should see a numerical difference that you can then compare in research, but also when you're training therapists. You're training the next generation of therapists to be able to say, okay, in our practice, we're striving for child-directed, task-specific, active play, which we know is evidence-based. If we as clinicians monitored that in our therapists who have been trained, we actually could say, we all do the same thing, but it's all driven around key principles that are evidence-based.
That's wonderful. I mean, my thoughts are going everywhere at the moment. So many things to think about. Let me see if I can bring it in.
Okay.
So you're really saying that, you know, we have names for certain therapies and interventions, right? That like sometimes are sold.
Yes.
So this could be a great way of kind of going, let's not even look at that. Let's look at the means of how this is being carried out. And now you're actually comparing 2 equal things in a way. Like it's not apples and oranges anymore. You're kind of going, okay, we're looking at play. We're looking at the medium, the means of play. And there'll be interventions that are very hands-on. Well, clearly that's not going to meet it. But if you're less hands-on and you can change elements of it, you can gradually pull yourself back and intervene with more active ingredients.
Absolutely. And it's a matter of you knowing what the active ingredients you're going for are. And if you as a therapist don't know what those active ingredients are, you need to go back to the literature. Because we do have evidence now.
We do.
For what the active ingredients should be.
Yes.
And if those active ingredients aren't a part of your session, you're probably doing something that's not effective.
I love that so much. So I can imagine with a lot of therapists going through this process, they can self-mark, they can do all of that. Is that available now for them to start looking at and evaluating for themselves? What's the process you think they could go through if they go, hey, I'm putting myself up for this?
Yeah, there's a variety of different systems for measuring fidelity. And some people do it in a checklist format, which is much faster to kind of check off, are you doing this at all during the session? And then there are really in-depth monitoring systems for fidelity that are more that kind of minute-by-minute scoring that I would say that we did as part of research, and to define the differences between usual care and the interventions that we were doing research on. But there are systems out there that are ready to roll for therapists to use if they know these are the key principles that were done in this research study. I want to emulate those because they have evidence of efficacy. And so if you're trying to implement a new intervention, you should be looking for, is that intervention evidence-based, and is there a fidelity metric that's associated with it? And fidelity then can be broken down into adherence, which is kind of, did you do what the key principles are? And then you can also use it for what we call program differentiation, which is the way you would compare 2 different programs against each other. Do they meet the same type of standards, or are they doing things differently?
Beautiful. How can this move to the next stage, I suppose? It's like almost from a policy perspective, isn't it? Because it's a way of defining evidence-based in a way, isn't it?
Well, I would love to see it become a policy-related issue that we said, you know what, you get reimbursed based on doing evidence-based practice, and you need to demonstrate that your team does it. To be able to show that that's effective, because we shouldn't be reimbursing for interventions that aren't effective. And we shouldn't be training our therapists to do things that we know have evidence either against them or that have no evidence.
Yeah, that's beautiful. That's a great call to action, Stacey. I love talking to you. I love it. It's so good. All right, so one final remark from you. What would you say is the one thing for all the listeners, clinicians, researchers, from the body of work that you've just talked about? I know it's a small part, big part. But what would you want them to really take home from this conference, from you and your team?
Yeah, I think the biggest thing is, one, we need to start earlier.
Yeah.
And we need to start in the lives of children and families. And we do that by play and by playing with them and helping families integrate play in a therapeutic way that will support their child's development while still being parents.
Phenomenal. I love that. And that's true, right? Because when it is play, you are parents to be parents,
absolutely.
not therapists.
Right. They're not little therapists. They're
That's
parents.
fantastic.
And they get to do the fun work of parenting and playing at the same time that they're helping to support their child's development.
That's just good for
they just need to know how.
family health. Yeah. That's perfect. Stacey, thank you so much. That was inspiring for me. And I know people who are listening to this will want to know more and follow on more, but we've got more to talk about for next time anyway. We'll tee up another podcast episode. To all of our listeners, thank you so much. I hope you really enjoyed that. As you can see, I was very excited by that whole episode and discussion. But it's a good call to action. Let's look at play. Play is what a child does, and it's a human right. So I'll talk to you all again really soon. Thanks and bye.